All right. So transfusion therapy is a broad term that, of course, encompasses all aspects of each blood component and also specific indications, for example, as well as expected outcomes and other considerations. So that is what you call transfusion therapy. So blood products that are used, of course, in transfusion therapy are different from just whole blood and its components, as well as plasma and its derivatives. So blood and blood products are considered as drugs. That is why we also have to know that the adverse effects as other drugs would also occur as well. For example, transfusion associated uh, transfusion associated hemolysis or hemolytic transfusion hemolytic transfusion reactions. So that is one of the adverse effects of transfusing blood products, because also they are considered as drugs. So sometimes also, apart from that one, we have also platelet refractoriness, which means that sometimes if someone has got a multiple transfusion of platelets, they will develop antibodies against platelets when you transfuse them. So because they are immunized, they will react and destroy platelets. So that's what you call platelet refractoriness. So platelets will be destroyed and rejected, so they will not be able to get adequate increments of what you are intending to get. So transfusion therapy can also be done primarily for uh, inadequacy of oxygen carrying capacity. For example, someone with anemia, that's the first purpose. And also the second purpose is, of course, to correct coagulation or hemostasis, to ensure hemostasis in case of platelets and factors. For example, of course, those are proteins, for example, clotting factors and other proteins. So that is, of course, to make sure that we restore hemostasis. So, but some patients, even if they have problems, they don't require transfusion. For example, like some patients who have anemia and sometimes even thrombocytopenia, but they are clinically stable. If they are stable clinically, in most cases, they don't require transfusion. So that's actually why we transfuse, and sometimes we don't need to transfuse because of clinical stability of our patient. So we can transfuse whole blood, but for a very few conditions, because the transfusion of this unit is limited. But of course, this whole blood must be a bioidentical, and the use of whole blood is just to replace the loss of both RBC and plasma volume. For example, you can say in major injury, in major trauma, if someone loses a lot of blood, the person loses RBC and plasma. So that will be loss of whole blood. So it means we can just use whole blood for transfusion, but we cannot transfuse whole blood to correct anemia. Even if anemia is severe, we cannot use whole blood, because otherwise, even if someone has anemia, but blood volume is adequate, so it means blood is normovolemic because of what we call compensation in order to restore blood volume, even if someone has very low RBC and hemoglobin. But in case of just immediate accident and loss of blood, we can still transfuse whole blood. So it means we can transfuse whole blood in case of anemia, whichever degree, but you can transfuse whole blood to correct the loss of blood, including, of course, RBC and plasma. So otherwise, of course, when you transfuse whole blood in case of anemia, for example, and someone with the problem of heart and even sometimes kidney failures, there will be a serious problem of overload, and as well as, of course, edema, pulmonary edema. Yes, because of even heart failure, because of the overload of blood. So because there is normovolemia, even if someone has anemia, does not mean that the person has low blood volume. So don't transfuse whole blood units. So then, as you remember, of course, when you transfuse whole blood, in case of loss of hematocrit and loss of hemoglobin and loss of RBC, we want to restore hemoglobin. So 1 unit of whole blood is going to increase at least 3% of hematocrit and 1 gram per deciliter of hemoglobin. So hemoglobin that is going to be achieved is 1 gram per 1 unit, and of course hematocrit of 3% after transfusion. That's about whole blood. So, but this is going to be, of course, apparent after 3 days. So to adjust hemoglobin and to adjust hematocrit, it must be 3% of hematocrit and 1 gram of hemoglobin, which is added after transfusing 1 unit of all blood. Now, what about RBC? RBC are also transfused, but RBC are transfused only for the purpose of increasing RBC mass, of course, to restore oxygen carrying capacity of the patient. So, and of course, as you remember, sometimes patients with the anemia, they would have serious problem of high levels of heartbeats, as well as respiration rates, and breath is really very quick. So those patients will also experience other symptoms of anemia, including dizziness and difficulty of thinking. So, and of course, there would be sometimes issues that will cause RBC to decrease in someone's blood. For example, the problem of decreased of production, like in aplastic anemia in leukemias, for example, and also decrease of survival, for example, in case of hemolysis, hemolytic anemias, and even surgical trauma or traumatic bleeding, surgical bleeding or trauma. Someone can lose a significant amount of RBC. So, in fact, no set hemoglobin levels is indicated for transfusion. So, but critical level of hemoglobin, which can trigger transfusion, it is hemoglobin of 6 grams per deciliter. But sometimes even less than 7, as in most cases, we need to transfuse blood in case of heart disease. If someone has concurrent or pre-existing heart disease with hemoglobin of 8, we can still transfuse blood or RBC. But never transfuse RBC to the patient who are well compensated. For example, if someone has anemia, even if it is very severe anemia, but it is because of nutrition. So that is what you call nutritional anemia. So don't transfuse RBC because this anemia is actually compensated. So in some other cases, pernicious anemia as well as iron deficiency anemia, there will be compensation. But if there is just a sign of decompensation, you can still transfuse the unit. So which means if someone is not stable clinically with anemia, so even if it is nutritional anemia, but there are signs of decompensation, it's very important to transfuse RBC. So when you transfuse 1 unit of RBC to the adult patient, it is going also to adjust 1 gram of hemoglobin and 3% of hematocrit levels. That is what we want to achieve in our patient: 3% and 1 gram of hemoglobin. So this is the same as all blood. All blood is the same as RBC. So in a pediatric patient, the story is different. In a pediatric patient, 1 dose of RBC to be transfused must be 10 to 15 milliliter per kilogram. So you don't just transfuse it. You don't just transfuse. You have to consider the dose. Dose must be 10 to 15 milliliter per kilogram. So when you transfuse, for example, our newborn has maybe 2 kilograms, for example, we can transfuse 30 milliliter of blood. So, but this is going to increase 2 to 3 grams per deciliter and 6 to 9% of hematocrit. That is for newborn or children. Pediatric infants and young children is going to increase at least 2 to 3 grams and 6 to 9% of hematocrit. So this will vary depending on the child age and body mass, of course. But of course, that is the range between 2 and 3 and 6 and 9 hematocrit. So and other units that you can transfuse, it is leukocytes. Leukocyte reduced RBC. That's what you call reduced RBC. So this is what we obtain after reducing leukocytes from RBC. So why do we transfuse leukocyte reduced RBC? Now, as you remember, leukocyte reduced RBC must contain less than 5 times 10 power 6 leukocytes. That is a rule, and Donor leukocyte may cause febrile non-hemolytic transfusion reactions and also transfusion-associated graft versus host disease, as well as transfusion-related immune suppression. So because of alloimmunization as well. So another problem also with the leukocyte reduction, it is cytomegalovirus. So in fact, to reduce the risk of HLI alloimmunization and cytomegalovirus, the leukocyte should be reduced to this level, less than 5 times 6 times 10 power 6, using leukocyte reducing filters. That's what you call microaggregate filters. So it is very important to remember that to reduce leukocyte, whichever you do to reduce leukocyte, does not grant that you are going to reduce the risk of TAGVHD. So reducing leukocyte does not remove the risk of transfusion-associated graft versus host disease. So we can do this when we do reduction and then we do irradiation of the unit. You can also transfuse what you call washed RBC and also deglycorized RBC, but as you remember, you can just wash RBC in order to avoid severe allergy. And you know, severe allergy is associated with anti-immunoglobulin A, anti-IgA, sometimes which is produced by patients with no IgA immunoglobulin. So those patients don't transfuse blood which is not washed, because they are going to develop a serious reaction which is called anaphylactic reaction. So, but also we can deglycerize RBC, of course, after freezing it, and then deglycerize it in order to transfuse to patients with rare blood groups, for example, and in some cases, of course, intrauterine transfusion. So we can keep blood for intrauterine, or sometimes we can also keep blood for autologous transfusion, and we just freeze it and deglycerize it. And of course, before we transfuse it, we have to deglycerize it and wash it. So then when it is deglycerized and is washed in open system, we must transfuse RBC within 24 hours after thawing. But of course, in closed system, it can even last for 2 weeks. That's the rule of deglycerized RBC and washed RBC. So, in fact, we expect the same post-transfusion survival of RBC, even if RBC had been frozen for a long time, and before we transfuse, we have to deglycerize it. We expect the post-transfusion survival as the same as a fresh drawn unit, right? It is almost the same because all RBC are alive. So, and also hematocrit that we expect from this deglycerized RBC is going to be the same hematocrit we expect from regular units or fresh units. So we can also do what you call a rejuvenation of RBC. So, and then we transfuse it, and we call it transfusion therapy using rejuvenated RBC. Why do we do rejuvenation? So to rejuvenate blood, it is to add elements or to add nutrients or to add the necessary elements or necessary nutritional requirements for RBC. For example, if RBC is prepared and stored in CPD and CPA, as well as ACG, AS, and it is stored up to 3 days after expiration. So, for example, if RBC has been there and it has expired, the unit of RBC has expired even up to 3 days after expiration, we can add some elements, including inosine, phosphates, as well as adenine, in order to rejuvenate RBC. So that is the purpose of restoration of 2,3-biphosphoglycerate and ATP in order to make RBC work. So I'm going to ask just a simple question here. Why do we need to restore 2,3-biphosphoglycerate for RBC? Obviously, 2,3-biphosphoglycerate has been lost throughout storage, but why do we need to restore this 2,3-BPG? Yes, Xavier. Why do we need to restore the 2,3 BPG? Mm. All right, thank you so much. Very nice answer. So we have to restore 2,3 BPG. I just want to find out if you guys remember the function of this 2,3 BPG back in hematology. We discussed 2,3 biphosphoglycerate. This is a product which is produced, of course, in what you call Laporte rebuilding pathway, in the diversion of normal diversion of normal glucolysis. So there is a production of 2,3 biphosphoglycerate, which is actually there, and it is to ensure that there is adequate oxygen delivery to tissues, because it is able to bind hemoglobin, especially globin chain better, in order to somehow stretch. It stretches hemoglobin in order to release oxygen to tissues. That's the function of 2,3 biphosphoglycerate. So, and remember, it can deplete almost completely after 2 weeks of storage. That is for information. It can deplete completely after two weeks of storage, and by the time RBC is expired, you find that it contains nothing when it comes to 2,3 biphosphoglycerate. So we have to adjust it in order to make RBC, after transfusing, make it able to deliver oxygen, because that is the first function of RBCs. And of course, ATP is also important because it is energy source. All right. So when you are going to transfuse this unit, even though it is washed, you have to. I mean, even though it is now rejuvenated, you must wash it first before transfusing, because those products that you use to rejuvenate it, they are toxic. So to prevent them, you must wash it, and of course you can transfuse it after 24 hours, or you can even freeze it for a long time. But if you want to transfuse it after rejuvenation, just rejuvenate it and then wash it and transfuse it within 24 hours after washing. Then another thing which is very important as well, it is also platelet transfusion. So platelet, of course, with the patient with the severe thrombocytopenia and abnormal platelet, they may experience bleeding problems, right? So thrombocytopenia can be caused by so many things. For example, malignancies, destruction of platelets. So that can cause it, and sometimes even massive transfusion can also cause thrombocytopenia because of dilution effects. If you are transfusing, for example, plasma or even RBC concentrates, you are diluting blood, so that, and also because if you are transfusing, it is somehow that platelets are being activated slowly. They are being activated because you are pulling blood in someone's body. So platelets are also consumed in that way. So that's why when you're transfusing, apart from dilution effects, even transfusion affect platelets. So you must at least also be able to transfuse platelets. So, but the first indication of platelets, it is for bleeding patients, and those patients who are bleeding, they also have thrombocytopenia. Not everyone who is bleeding that can transfuse platelets. So, and even if someone has dysfunctional platelets, and sometimes even if someone does not have a disease, but the person has platelets of less than 10,000, if platelet is less than 10,000, that person, you must transfuse platelets regardless of clinical stability. So you must transfuse platelets. That's also one of ACP questions. Sometimes they will ask you, what's the number of platelets that can trigger transfusion of platelets for the patient if there is no condition of disease, for example, no bleeding. So you must remember it is between 5,000 to 10,000. then you must transfuse platelet as prophylaxis. So because of course platelets they are also of course prone to bacterial infections, it's very important sometimes that you have one unit and culture it in order to check there's no infection there. So in fact, when you transfuse 1 unit of platelet by apheresis, you remember it is equivalent to 6 units of platelets by random donor. So it is going to adjust to increase, right? You have to remember this one. Some people they confuse. Let me show you what they confuse. I've seen too many people they confuse this number and this number. The two numbers are different. One number is 5,000, another number is 20,000. So 5,000 means this is a number at which you transfuse platelets. When you see this number, this one you have to give prophylaxis of platelets. But 20,000 to 60,000, this is the number or count, what we call increments of platelets, the adjust platelet or increase of platelet to the patient after transfusing 1 unit, especially of course 1 unit of apheresis. It increased 20,000 to 60,000. And random donor platelet, of course, in order to achieve that, you must of course transfuse 6 units. But when you transfuse 1 random donor platelet, it is going to increase 5,000 to 10,000 in 70 kg patients. So it means now the number of platelets that a random donor platelet is going to increase to the patient, it is equal to number of platelets that can trigger transfusion in clinically stable patients. So it is 5,000 to 10,000. Okay, so that is for platelets. So we have seen the different reasons why we transfuse platelets. Okay, and then we can also transfuse, of course, leukocytes or white blood cells. You can transfuse white blood cell, and in most cases, of course, you can transfuse white blood cell if there is a problem of fever, or sometimes even if there is no fever but neutrophil count is less than 0.5 times 10 power 3, which means it is less than 500, isn't it? 500 and 500 per microliter. And septicemia, maybe bacterial infection, sometimes unresponsive to antibiotics, we can transfuse leukocytes, that is granulocytes. So for adult patient or a child, the usual dose is 1 granulocyte apheresis product daily for 4 more days, or for 4 or more days. We have to give 1 unit of granulocyte apheresis for 1 day, for 4 days, but daily 1 product, 1 unit for 4 days, or sometimes more than that, in case of course patient is still experiencing the same condition. So, but for neonates, what happened for neonates? I mean, these are neonates, or so neonates just those immature, like premature infants, those neonates. A portion of granulocytes apheresis unit is given once or twice in a day, right? But granulocytes which contain less than 1.0 times 10 power 10 granulocytes, as well as platelets and 20 to 50 milliliter of erythrocytes, so they are given together. So because the patient receiving granulocytes are immunosuppressed, sometimes immunocompromised, so we must irradiate it, because of course even if it is not a blood relative, we must irradiate granulocytes. Let me repeat that. We must irradiate granulocyte regardless of being a relative or blood relative or not, because patients who are receiving platelets, they are normally, who are receiving leukocytes, they are normally immunocompromised. So we don't expect their immune system to recognize T lymphocyte and remove them or destroy them. So we don't expect that. So that's why we have to help our patients by irradiating blood before transfusing, because otherwise, even if it is not a blood relative, sometimes you find that transfusion-associated graft-host disease is going to be a problem. So that is about leukocytes. But also leukocytes, of course, granulocytes are not cannot, if they cannot be transfused immediately after apheresis, we have to store them at room temperature like platelet. You remember that granulocytes are stored at the same temperature as platelets. So that is 24 degrees, but without agitation. You know, we store platelet with agitation, but granulocytes are stored without agitation, and granulocyte must be stored for maximum 24 hours shelf life. That is for granulocytes. And if granulocytes need to be cross-matched, of course, you must send a pilot tube if there seems to contain RBC. So you must send a pilot tube. And then finally, we have the final product here we're going to talk about is platelets. Is plasma. It is plasma and its products. Plasma can be transfused in many ways as FFP, remember, fresh frozen plasma, PF24, as well as liquid plasma and cryoprecipitates. They are all plasmas. So, of course, FFP contains so many factors, and including non-labile factors, and FFP also contains other factors like factor 5 and factor 8, which are also labile, but PF24 it doesn't contain a factor 8 in adequate number, in adequate amount. In fact, FFP is better than PF24 because FFP contains factor 8 and 5 in adequate amount, whereas PF24 doesn't. So after thawing FFP, of course, we have to keep it immediately. Store it at fridge temperature, which means 1 to 6 degrees. But after 24 hours, when you don't transfuse it, remember we have to label it as thawed plasma. And if it was collected in an open system, we can transfuse it even within 5 days. But remember that some of the label factors like factor 8 and 5 are no longer there, or they are very, very reduced. So, but you remember that sometimes PF24 is also transfused, which we call plasma frozen within 24 hours. It is called PF24RT24. So that is the plasma that we corrected and is held at room temperature up to 24 hours, and then we freeze it. That's what we call PF24RT24. So it is similar. It is similar to FFP in treatment, where like intention or even treatment like handling FFP, and the way we handle PF24 is the same. Like we can thaw it and store at fridge temperature. We transfuse it in 1 day, and sometimes if not possible, then we can also keep it for 5 days, and of course you have to label it as thawed plasma, and if not discarded, you can label it as thawed plasma and transfuse it for 5 days. So the purpose or indication of plasma transfusion, plasma is used to treat multiple coagulation deficiencies. In case of liver failure, disseminated intravascular coagulation, vitamin K deficiency, warfarin overdose, as well as massive transfusion, and sometimes even single deficiencies can also trigger FFP, for example, factor 11. Because there is no factor 11 concentrates out there, we can use even a plasma to restore factor 11. So factor 11, which is called Rosento syndrome. Rosento syndrome, it is deficiency of factor 11. I hope you also remember disorders. Associated with clotting factors. Factor 11 deficiency is called Rosento syndrome, whereas factor 9 and 8, all of them are called hemophilia. Right? So we can correct the Rosento syndrome as well as these other problems like multiple coagulation deficiency. But multiple coagulation deficiency is the first the first indication, is the first disease for which plasma is indicated, this multiple coagulation deficiency. But otherwise also liver failure, DIC, and many others we can also use plasma. We can also sometimes use it as fluid replacement fluid during plasma exchange in case of TTP. Remember TTP? Can also use carrier-reduced plasma. So we talked about, or almost already we talked about cryoprecipitates and why do we transfuse cryoprecipitates. It contains so many factors: fibrinogen, factor 8, factor 13, von Wildband factors, fibronectin, and even cryoglobulin. Here it's not listed, but it's also there. But the main reason of transfusing cryoprecipitate, it is what we call fibrinogen replacement. It is the first reason of transfusing cryoprecipitate. But we can also, of course, transfuse it for other problems like vitamin A, factor 8 deficiency, factor 13, and many others. And it must contain at least more than 150 milligram of fibrinogen, whereas, of course, in some cases, it can even be over 250. At least it must contain more than 150 milligram of fibrinogen. Otherwise, it also contains 80 international units of anti-hemophilic factor activity. So that's very important. So we can also pull them together, and then you can label them as pooled cryoprecipitate anti-hemophilic factor, and then you transfuse them as pooled. But remember, you can still pull up to 10 units for the patients. So this is the purpose, and of course, fibrinogen is one of the most important disorders for which cryoprecipitate is indicated. So as you remember, also we talked about cryopoor plasma. Cryopoor plasma, we said it is just that plasma from which cryoprecipitate is extracted. So we can also treat the same way as fresh frozen plasma. So every plasma is treated the same way. Also, cryopoor plasma, we treat the same, or we handle it as the same as FFP, thawing temperature, storage temperature, the same. But of course, we are looking for other factors that are not extracted along with cryoprecipitate. Those factors include ADMTS13, factor 9, factor 2, 5, 7, 8, 9, 7, 9, 10, and 11. But some factors are not there because they have been lost in cryoprecipitate content. So what is the function of this stuff here? ADMTS13. What's the function of this molecule? What's the function of ADMTS13? What's the function of this molecule? ADMTS13. It's the first time to say it? I think not. Not the first time to see it. ADMT13, what the function of it? Yes, Xavier, do you want to try it? Yes. Yeah, it is to cleave von Wildband factor metameric molecule in order to make it active, because von Wildband factor will actually help platelets in their adhesion. So it works properly when it is cleaved and split into small fragments. So that is done by that ADMTS13. Thank you so much. That is really correct. So now factor 8 is also, of course, transfused, which is also a plasma product. Factor 8 is transfused for hemophilia A, and of course, which is factor 8 deficiency is hemophilia A or classic hemophilia. It is actually derived from recombinant DNA technology, but you can also of course correct it and prepare it in plasma.